The United in Compassion Medicinal Cannabis Symposium will be held in Sydney from the 9th to the 11th of October 2020. For more information and to book your ticket, click on Events under the Community tab at fxmedicine.com.au. This is FX Medicine. I'm Andrew Whitfield Cook. Joining us on the line today is Tanya Wells, a naturopath who's been practicing for over 20 years, and she's a special interest and expertise in the research and development of integrative oncology programs, utilising the best evidence-based complementary therapies to work in conjunction with conventional treatments such as surgery, chemotherapy and radiotherapy. She's visited and worked in integrative oncology hospitals in Europe and Asia and is continually collaborating with other practitioners to ensure her programs and clinic models are continually being developed. Tanya is an experienced lecturer at the tertiary level, including at Southern School of Natural Therapies and Endeavour College, as well as the Faculty of Medicine at Monash University. She's written and presented a range of drug-herb-nutrient interaction seminars for medical, pharmacy and nursing professionals in integrative medicine. And she's a contributing author to a range of clinical textbooks. Welcome to FX Medicine, Tanya. How are you?
Great. Thanks very much for the introduction, Andrew.
Tanya, you've got a long experience in helping people with cancer. Today we're going to be talking about breast cancer and recurrence of ER-positive breast cancers. It's not all about the oestrogen. So I think first, though, we've got to talk about the different types of breast cancer.
Yes. I guess we wanted to have a chat about breast cancer because it definitely is the most common type of cancer that you'll see in clinic. I think the current stat is heading towards 1 in 7 women will have a lifetime incidence of breast cancer. And certainly as complementary therapists, we get a lot of patients in looking for that extra help during that process. So the vast majority of those breast cancers are estrogen positive or ER positive breast cancers. But I guess the first thing we do need to talk about is the different types. So when someone's diagnosed with breast cancer or they have a lump, something shows up on a mammogram or an ultrasound or they feel it, most of the time they'll have a biopsy, which we're looking for one of 3 receptivity markers. So this includes ER, which is estrogen, PR, progesterone, and HER2, which is a epidermal growth factor receptor. And each of those is determined to be positive or negative, determining whether the cancer cells are receptive to those growth factors or hormones. So the most common types of breast cancer are ER, PR positive, HER2 negative, which is about 70%, ER, PR negative, HER2 positive, which is about 20%. Then we've got triple negative or basal-like, which means that none of those receptors are positive. And then we've got triple positive, about 10% each. And the treatment of prognosis of each of those types of cancer is very different.
Yeah.
Yeah, so we thought today we'd focus on the ER positive ones though, because they are the ones that are the most common.
When we're talking about biopsying a lump and you go for fine needle versus core, tell us a little bit about the expectant results of those and really what happens with women.
Okay. So the fine needle biopsy, I think, has unanimously been found to be not very effective as a testing tool. A core biopsy is a much bigger sample of tissue that's taken, but it just means that you are going to get a reliable outcome from that test. The worst thing you want to do is have a fine needle biopsy or multiple fine needle biopsies and then have to go in and have a core biopsy or something else afterwards. So we usually just want to go straight to the most appropriate test.
Like I know people would like to shirk on or err on the side of less invasive techniques, but I just don't understand why it's more than likely that it's going to progress to have a core biopsy as well. So why would you bother with the fine needle biopsy at all?
Well, most of the time you wouldn't.
Yeah,
I wouldn't recommend it.
I just don't understand it. When it's kind of like, you know what's going to happen anyway, so it's like, why bother with the first one? Because all you're really doing is 2 procedures rather than 1.
Yes, and you're more likely to, it just creates more stress, because not only is the most stressful time for patients the wait between having a test and getting the result, but also you're going to get a result that's inconclusive. So then you have to go through the whole thing again, which is just torturous.
Yeah, absolutely. Torturous on many levels.
Yes.
So let's talk about the role of estrogen in ER-positive breast cancer.
Yeah. I guess there's a couple of big messages that I'd really like to make clear, because, I I chat with a lot of other practitioners, and most practitioners are very confused about the role of estrogen. I get questions like, what? Every woman has estrogen, so why doesn't every woman get ER-positive breast cancer? Is it really causing the cancer? What does it do? How do we work it out? It's very confusing. So I guess I wanted to focus on 2 things today. One, to talk about exactly what is the role. Is estrogen causing damage, and if so, what damage? And then we also want to talk about non-estrogen areas, because the current medical model totally focuses on estrogen. That is the main long-term preventative support, in that you're on an anti-estrogen of some sort, either something that's going to block its synthesis, like an aromatase inhibitor, or something that's going to block that binding of estrogen to the receptors, like tamoxifen. So it's not all about the estrogen, but I guess firstly we need to talk about what it does. So estrogen, we know of estrogen as being a growth promotant. It's certainly responsible for our secondary sex characteristics, but it has a role to play in DNA damage. So we have to take a step back then and say, okay, well, which people are more likely to have that estrogenic kind of genotype? There is such thing as an estrogen-responsive genotype, and some women have that. As a naturopath and complementary therapist, we'd often talk about someone who presents with an estrogen-dominant kind of clinical picture. And those patients we'd often see who had, early menarche, so their first period was quite young. They seem to have an estrogen-dominant status, conditions like fibroids of the breast and the uterus, endometriosis, heavy bleeds, PCOS, those kinds of things that tend to look like an estrogen-dominant picture. But I guess we do want to look at that person's lifetime exposure to estrogen, not just endogenous estrogen, but also environmental estrogens, like plastic extracts like BPA and phthalates and parabens and other BPAs, so on. So all of those things contribute to your overall estrogenic status. And the estrogen actually can cause DNA damage, especially if you've had a very long lifetime of exposure to estrogen. So women who got their period very young either didn't have any children or have children late. So we've got a lot of exposure to estrogen, and of course we've got breast tissue which is constantly being stimulated by estrogen. And one thing we know about in oncology is that the tissues that turn over the most frequently, so those that are replacing themselves really frequently, tend to be the ones where there's more opportunity to make mistakes. There's more opportunity for those cells to make errors when they're replacing themselves. And of course in our breast tissue, we've got breast tissue that's developing in the luteal phase every cycle, hoping that your body's going to get pregnant. We've got partial development of that breast tissue. And of course, then it kind of shrinks down again when you get our period, and it grows again, and it's constantly in a state of development and stimulation. So that estrogen is very important with regards to cause and effect inferences. The way that it actually causes damage is mostly via it being so reactive. Certain types of estrogen are reactive and they can cause DNA damage.
Can I just go back a little bit? You were talking about estrogen dominant. I get confused by this because I thought that it was kind of like adrenal fatigue. We really had to leave that term behind. That it was estrogen driven, but not necessarily dominant, because of course estrogen is cyclical.
That's right.
So is it just a convenience term that we're talking about here, or is it actually a dominant type?
No, it is a convenience term. I guess I'm going back to, the phrases that I learned when I was studying
I do it
naturopathy.
all the time.
Yeah.
Is it true, though, we have to leave that term behind, that we say estrogen dominant, but we really mean estrogen driven?
Yes, that's right. I mean, I guess we all say these phrases because they're things that people relate to. They can understand what we're talking about on some level, but certainly there's not a lot of evidence that shows that a person has necessarily an estrogen dominant scenario. It is estrogen driven, and certainly people have a higher level of active estrogens. And I guess that's what we need to talk about. What are the factors that contribute to someone having a very high level of these active and reactive estrogens that are more likely to create problems?
And indeed, is it just the hormone? I know that they're hormonally sensitive receptors, but is it just the estrogen that causes the cancer, given that we've got the inflammatory microenvironment, we've got the two-hit hypothesis, we've got the metabolites of the estrogen, we've got xenoestrogens ubiquitously and continuously in our environment. We've now had researchers testing their friend researchers' poo, and now this wasn't in Australia, it was Asia and Europe, but they've tested not microplastics but lumps of plastic in their colleagues' poo. I mean, this is not a concern, this is frightening. So we now know, it's unequivocal that we've got constant xenoestrogenic drivers. Correct? Is that right?
We do, and certainly when you test for xenoestrogens, we certainly have ways of testing your metabolites and so on, and that is something that we can test for and we are exposed. There are so many other factors, such as, dysregulated metabolism, insulin resistance, inflammation, chronic stress, NF-kappa B issues and gene expression, obesity, exposure to radiation and so on. All of these things contribute to your oncogenic potential in every type of cancer. And there are some that are certainly far more associated with ER-positive breast cancers, like insulin resistance. Certainly that is the number one factor to check.
Gotcha.
Because we know that insulin resistance can create an inflammatory state, which not only promotes growth but can lead to treatment failure. So we have so many factors that are non-estrogenic that we can focus on as clinicians, and this is where we have a role to play. We have a role to play to add success to someone's treatment program. We have a role to play to create wellness. Coming back to estrogen, I think that we really do need to have a chat about, exactly getting down to that nitty-gritty. How is estrogen metabolized? What are the different types? And how are they working in a reactive way? So getting down to that, the real issue in estrogen is actually estrogen metabolism. So when it comes to estrogen metabolism, we have to go back to our very basic knowledge as clinicians, and that's about phase 1 and 2 detox, liver detox. So phase 1 detox is converting those raw compounds into intermediate metabolites, and that's mostly via cytochrome P450 enzymes present in the liver and the breast tissue. And then we've got phase 2 pathways. So there are a number of types of estrogen that can be formed through the metabolism pathways. And we can test for all of these things, but certainly the big ones are the 2-OH pathway, which is produced by sulfation, 4-OH and 16-OH pathways. And these are the ones, the 4-OH and 16-OH pathways are active forms of estrogen. They're far more likely to cause DNA damage because they're reactive. And this is where we actually have a huge role to play in modifying these metabolism pathways to reduce levels of 4-OH or 16-OH and increase 2-OH forms of estrogen, which are anti-estrogen. In fact, they reduce growth and proliferation because they have a very low binding affinity to those receptors. So this is where we can actually use our knowledge of the detoxification process to intervene and change the way that the estrogen balance in the body occurs.
And of course, one of the best ways in which we can do this is our good old number one treatment from an integrative perspective, or any perspective, and that is exercise.
Well, yes, absolutely. Yeah, I mean, look, there's research that shows that even if you've never exercised in your life and you've had a breast cancer diagnosis, if you actually start exercising for the first time ever, you reduce your risk of recurrence by 50%.
Yeah.
You know, that's better than any treatment combined.
Yeah.
So absolutely, exercise is important. And that's also important for turning over those fat cells. You know, we store a form of estrogen, a very active form of estrogen, estriol, in our fat cells. So we want to turn over those cells to release that estriol and try to replace it with fat cells that don't contain as much estriol. So, you know, exercise is very important from a detoxification process, but also nutrients are important too. Like, we want to promote the sulfation pathways, methylation pathways, glutathione, and so on, to promote production of those inactive forms of estrogen, and we can do that very well nutritionally.
Sorry, Tanya, I don't mean to interject, but you're talking about estriol or estriol in the fat tissues, not estrone. Is that right?
Yes, that's right. So both estriol and estrone are found in fat. I guess when we think about the main three types of estrogen that are active in the body, sort of parent estrogens. Estradiol, of course, is produced by the developing follicles in the ovaries, and that's our most bioactive form of estrogen. And then we've got estrone, which is found in our fat cells a bit, but predominantly produced by the adrenals, especially postmenopausally. Yeah. That's the main source of estrogen postmenopausally. And then we've got estriol, or E3, which is it is a major form of estrogen found in pregnancy, interestingly, and also it is stored in our fat cells. So this is where women who have a high amount of fat, so those women who are obese, certainly have a very high level of overall estrogen, but the predominant type is estriol, followed by estrone in the fat cell.
So can I then ask a question? You know, estriol was, previously purported to be supposedly protective during pregnancy, and that's why low amounts of breast cancer were seen in pregnancy. But it's not unfound. There are certainly women that suffer breast cancer during a pregnancy. Would these women be the higher fat content ladies?
Not always. I guess when it comes to recurrence, we certainly have evidence that high levels of estriol from adipose tissue is a massive risk factor.
Right.
I can't remember the exact statistic, but there's a certain percentage of increased risk per 5 kilograms of overweight. And that's certainly something that's significant. But estriol is very important postmenopausally as a risk factor. And unfortunately, most of the research in breast cancer is in postmenopausal women because of, there's just not much research in women who are, possibly could be pregnant. We don't have many women participating in research that are premenopausal. But certainly all types of estrogen are important to have a look at. And estriol generally is the least bioactive form of estrogen that we've got there.
Right. And so, we were talking about estrogen metabolism, putting it in its place about that estrogen dominance. But some women do have high estrogen metabolite issues. And I know this is not a proven, science, that there still is conjecture about the relevance of estrogen metabolites, but by goodness, I've seen issue after issue after issue when you've got high fall.
Definitely. I think there is so much research and multiple reviews about the role of estrogen and the different types of estrogen in cellular proliferation and growth and damage and DNA damage. But certainly, and there's a bit of a disparity between the in vitro research that seems to have a very clear result and then the clinical research, which is a bit more ambiguous. Yeah. And then we've got premenopausal and postmenopausal issues. So, for example, 16-OH form of estrogen does seem to be associated with increased risk if you're premenopausal, but postmenopausally, not so much.
Okay.
So it depends on where you're at in your menstrual maturity, and but we do want to use these things. I use them clinically as a guide. I'm going to do that estrogen metabolite test and see exactly what my patient's current status is. Do they have really high levels of endogenous estrogens and high levels of these metabolites that we know are active? If we do, if that person does, then we have a role to play in providing support for sulfation, methylation, glutathione, and so on, to actually promote phase 2 detox of those active metabolites into more inactive forms.
Yeah. When we're talking about that, should we primarily be focusing on A, exercise, and B, things like fibre in our diet to clear overall estrogen from being recirculated, and then you add other things, to sort of nip things off at the bud, to tweak things? Or do you go in first with things that have a really strong effect on the ratios and the levels of the metabolites?
Well, I do a bit of everything.
Yeah.
So certainly I would go for the overall microbiome support, for high fibre, or not high fibre, but good level of fibre diet to make sure that we are getting that estrogen clearance, exercise to turn over those fat cells and promote clearance of estrogens again. But I guess I do get a bit more specific and individualised with patients. If you're finding that certain types of estrogen metabolites are elevated, we might give sulfur compounds to promote sulfation, like broccoli sprout extract, sulforaphane, indole 3-carbinol, and so on. Methyl donors, of course, and then there's glutathione-rich foods that I would mostly use that are supportive in phase 2 detox. But I guess then we do have to talk about diet as well. I know that there is a huge focus on diets like keto diet, and certainly we do want a low carbohydrate diet, especially in people who are morbidly obese.
Yeah, of course.
But a keto diet is not necessarily appropriate in healthy body weight patients. Certainly we want a low carbohydrate, but we also need to make sure we're getting plenty of fibre in there for an appropriate microbiome support.
So let's take this back to, when a patient presents to your clinic. How much leeway do you have before treatment is going to begin, and what sort of dietary measures do you engage in at different times of therapy?
Well, I see patients in every part of that spectrum, from, patients saying, I've just found out that I've got a BRCA gene, and there's no clinical presentation whatsoever, all the way through to initial diagnosis or precancerous cells, DCIS and so on, through to pre and post-surgery, chemo, radiation, everything, and then follow up into maintenance and prevention of recurrence. So I get patients coming who have started treatment, who are about to start treatment, or who have finished treatment. It's so variable. But certainly what I tend to do with ER-positive breast cancers is give a overall anti-inflammatory diet. You did touch on this previously about inflammation, and we do want an anti-inflammatory diet, which predominantly the research shows that a pesco-vegetarian diet is most appropriate.
Right.
And we do focus on that, a low carbohydrate pesco-veg / Mediterranean diet.
Okay, so you've got an acceptance there, though. Like there was some work done by Volta Longo and others. Indeed, Dominic D'Agostino is doing work, or forgive me, he knows the researchers that are doing other work in keto nutrition during cancer therapy. But it's, you've got an uphill battle trying to get the acceptance of an oncologist to instigate it.
It can be that way. I've found that I don't have a lot of trouble overall with communication with oncologists, maybe because I've been doing it for a long time. But certainly the oncologist is quite happy typically to interact in a positive way and doesn't usually have much of an opinion about diet. But certainly keto is very hard for the patient.
Sure.
And it's something that's a bit hard to maintain. And although I've definitely read the research about ketogenic diet as being helpful, and certainly taking elements from that research is important, what I've seen clinically is that patients who get too into keto actually put themselves at risk of kidney damage during treatment.
Now there's a salient point.
Yeah, we have to be quite careful about a ketogenic diet. When you're in ketosis, you do need a huge amount of water intake every day in order to get rid of all those ketones and support kidney function. And certainly when patients are in chemotherapy, which then gives even further kidney risk, we certainly need to be very careful with implementing that diet during treatment.
Yeah.
And it's not just that, but also kidney function. I mean, if you look at...
It's the biggest red flag you've waved. It's brilliant.
Yeah, it's just the basic knowledge we have about the kidneys. For example, when you look at a kidney function test and you see, the glomerular filtration rate should be above 90. Well, actually, that's in men. A lot of women have a glomerular filtration rate less than 90 naturally, and that's just because most of the research about, what is an appropriate glomerular filtration rate has been conducted in men. So this is where we have to think about that when it comes to the issues around things like ketogenic diet during treatment. We have to look after our kidneys as women.
Absolutely. And, notwithstanding that you're on extremely toxic treatments that have got to be dispelled from the body.
That's right.
Thank you. I really, really thank you. That is a light bulb moment for me. Whereas the Mediterranean style type diet is socially acceptable, culturally acceptable, so much more easy to instigate.
There is, and certainly what you can do is take elements from each of these diets that's appropriate. And it's definitely not a one-size-fits-all program in oncology, and it's not everyone should be keto or everyone should be paleo or everyone should be vegan. It's not necessarily the case. Yes, there's certainly evidence about a ketogenic diet being appropriate for certain types of brain tumours or again, morbidly obese women with ER-positive breast cancer may be appropriate, or those that have diabetes as well. But when it comes to making it easy for the patient is in a world of pain, emotionally, environmentally, physically, and this is where we need to make sure that as clinicians, we're realistic. We're looking at this not only from a pathophysiological perspective, but also putting ourselves in that patient's shoes and going, what could I cope with if I was in this space? If I was having to cook for myself, do everything for myself, and I didn't have that support team doing it for me, and even if I do have a support team, what can I expect from them to be able to make me and support me with? A low carbohydrate Mediterranean pesco-vegetarian diet is appropriate. And if you want to take elements from other research, this is where we might do a little bit of intermittent fasting pre and post chemotherapy may be helpful. Exercise on the day of chemotherapy has certainly been proven to be helpful. We take elements from the rest of that research to try to tailor each person's plan, individualise it to make sure that we're maximising the successful outcomes, and then we're supporting them in every other way, including supporting their liver and kidney function.
Can you just reiterate the fasting, the intermittent fasting around the chemotherapy episode?
There's a lot of research emerging about intermittent fasting, and most of it is about breast cancer. And there's multiple types of intermittent fasting. So there's extended overnight fasting, which can be helpful. Certainly that's been shown to improve insulin-like growth factor levels. It does reduce inflammatory chemical levels, inflammatory mediator levels. And so I do recommend an extended overnight fast on an everyday basis. So 13 to 15 hour extended overnight fast, especially in women who are overweight or obese. But around chemotherapy, it's more about having a 24-hour fast before or after chemo, especially before, that it does induce a mildly I don't want to say ketogenic, but it is kind of a mildly ketogenic state where you actually do have a fast just prior to having chemotherapy, and that puts those cancer cells in a glucose-depleted state.
Yep.
If women are morbidly obese and they have ER-positive breast cancer, it is the case that those cancer cells do use up more glucose than the surrounding cells. But having that intermittent fast prior to chemotherapy puts those cells in that sort of relative glucose deficiency. You have the chemotherapy and then straight away have a snack.
Yep.
And that means that the cancer cells are going, sugar, I'm going to have, a carbohydrate snack that's going to increase absorption of the glucose and the chemotherapy into those cells.
Yeah. So sorry, I want to get this clear in my mind because I battle with this. So what you're saying is fasting more than prior, and then just prior you have a little snack?
Just during treatment.
During treatment you have a snack?
Yeah.
Gotcha.
Yeah. A healthy, complex carbohydrate snack, but certainly you don't want to have, a Scotch finger biscuit or something, but certainly a healthy complex carbohydrate snack is going to, improve theoretically, and certainly according to some in vitro and in vivo research that shows that it does support transport of the treatment into the cancer cells. So we're just trying to tailor the chemistry of the body in that exact moment to improve delivery of the chemotherapy to the target cells, which is very difficult.
Okay, and obviously you've got challenges there. We've spoken about the estrogen metabolites briefly. Let's go a little bit further into that. What exactly do you use and why?
Well, when it comes down to actual treatment, apart from our anti-inflammatory diet, exercise, we're really wanting to support that person's stress response, immune system and so on. I guess when it comes down to the nitty-gritty of estrogen metabolism, we do need to make sure that we've got appropriate support for each of those phase 2 pathways. So sulfation pathway, the broccoli sprout extract, it definitely has shown to be the most powerful extract. And so you can actually just make your own broccoli sprouts, or you can get a broccoli sprout extract like sulforaphane, which has been researched as an independent sulfur compound.
Yep.
To not only support sulfation but also be anti-cancer. It certainly switches on DNA repair genes, and it has multiple other roles in an anti-cancer pathway. But there's others too, like indole-3 carbinol, diindolylmethane, calcium D-glucarate, that are all involved in sulfation. And I do tend to give all of those as a package to support that sulfation pathway rather than just broccoli sprout extract or sulforaphane. I do find that when I'm monitoring patients, so I do tend to do some estrogen metabolite testing as a baseline, and then every 3 or 4 months to check in and make sure that we are tailoring those doses required for that individual in real time, making sure that we are keeping up to date with how the estrogen metabolite balance is going. And I do tend to give all of those sulfur compounds as well as methyl donors to support methylation, and, of course, glutathione, either as a supplement or as glutathione-rich foods. Actually, I did want to make a point there about methylation, in that this is where you might want to do an MTHFR test.
Yeah.
Certainly there was a review in 2017 that showed that the MTHFR C677T mutation, far more common in ER-positive breast cancer patient populations.
Okay.
So it is something that, if you've got someone who does have that MTHFR mutation, it may contribute to poor methylation, which then has an effect on estrogen metabolites.
When we're looking at methylation, do we want to be doubly sure that we're handling everything that happens with quieting the genes, if you like? So when you're talking about the sulforaphane, the broccoli sprout extract, that we're making sure that we're doing the best that we can for that patient to actually get rid of the drivers of those cancers, not just, quote unquote, looking at methylation. Is that
Yes.
something you're like just really on the ball about?
Absolutely. But when it comes to DNA and DNA repair and DNA mutations, gene mutations that may actually contribute to ER-positive breast cancer recurrence, there is a huge body of research about that, and certainly we can certainly delve deeper into that with regards to there's a few key cancer susceptibility genes that we do need to be aware of. It's not all about the MTHFR, it's not all about sulfation. We do need to step back and look at the bigger picture and say, okay, these are all of the things that we know are relevant in this situation and try to prioritise accordingly. And certainly we may have information already that person has presented about their genetic status and whether they have any gene mutations or SNPs or whatever they might be testing for. And then we actually can intervene in those processes as well. It's a pretty common scenario that a patient comes in with genetic testing that's already been done.
Okay. Yep.
And
I've got to say, I wonder if the day's coming where we'll just carry it around like we always carry around our driver's license. It's something that we have, whether we want to use it or not. Well, that's our own choice. But I guess the problem is people who don't know what they're carrying around or what they're doing. There's always that concern.
And even if you do, it's not necessarily a done deal. I know a lot of patients who say, oh, well, I've got this gene, so therefore, I'm going to get this type of cancer. That's not true.
No,
we actually have
right.
ways of intervening in the expression of that gene, and there are ways of switching on DNA repair genes that, down-regulate the expression of all sorts of oncogenic gene mutations. We have a lot of impact in this area, and we know a lot about it. For example, BRCA gene. The BRCA gene is a tumour suppressor gene involved in DNA repair, and this does contribute to incidence of breast cancer, but it doesn't seem to relate too much to recurrence. But certainly women who have a BRCA gene, I think there's something like a 50 to 70% lifetime risk of breast cancer versus 12% with no BRCA. But and it also contributes to ovarian cancer incidence. But, we used to think that some substances like genistein and indole 3-carbinol only targets the estrogen receptors. But now we know that these natural medicines actually down-regulate the expression of the BRCA1 and 2 genes themselves. They're the molecular target, not necessarily the estrogen receptor. So we actually have a growing body of research that shows that, an intervention is possible when it comes to existing gene mutations.
We have so much of a rabbit hole to go down there, Tanya, but let's pull it back a bit. Let's go down a little bit further into testing. What testing do you do and why?
Well, it depends on the patient. Certainly depends on how they're presenting and their other known disease states. But I guess general things that I would test for, I would definitely do a dried urine estrogen metabolite test.
Yep.
There's been, I was actually just reading about this the other day about whether that test is actually valid. It does definitely seem to be more valid than just a standard blood test. It certainly is telling us a lot more about the way that the body is working. And I do tend to use that urine metabolite test more than serum testing. I would definitely do MTHFR testing. I also look for other nutrients that are relevant when it comes to phase 1 and 2 detox, like selenium, vitamin D levels. I often do a cytokine profile because I want to see what some carcinogenic interleukins like IL-6 or the insulin-like growth factor levels are. And sometimes I'll do CTC testing, so that's circulating tumour cell testing. It is very expensive, and I don't always think that it's relevant to do that. I'd like to see what's happening in the chemistry of that person's body at the time, and that's why the estrogen metabolite test really is important. Because it's looking at not only the different forms of estrogen that have been broken down, also looks at your level of BPA, cortisol and cortisone levels, melatonin and other things that are relevant from an anti-cancer perspective.
And what about frequency of testing? I mean, obviously, for instance, if you're going to be looking at something that's going to influence estrogen metabolites, you want a baseline, and then you want to see if you've done good work.
That's right. All of this, of course, is dependent upon whether that person's taking an aromatase inhibitor. If you're on an aromatase inhibitor, that pretty much puts your estrogen levels at zero because it's reducing the conversion of testosterone to estrogen. So, that's going to skew the results. But if you've got someone who is not on an aromatase inhibitor, you do want to take that estrogen metabolite test as a baseline.
Mm-hmm.
Then you are implementing treatment. So you're obviously stimulating sulfation or methylation or glutathione. And then I would tend to test about every 3 or 4 months, 3 months at the beginning, just to really make sure that we are individualising the dosage for that patient and making sure that we're changing it kind of in real time. We really want to see the impact of our treatment. And you could do it every 2 months if you really wanted to, but I'd say every 3 months just so that we can check in on that particular part of the treatment and support plan and make sure that we're having an effect. We want to make sure we're monitoring that.
We've spoken about what do you do if the levels are high. What about really high? Like, what about dangerous?
That's where you have to look at integrative care in a way that is appropriate for the patient. And we do often give much higher dosages of support from a complementary medicine perspective. And that's definitely where an argument for an anti-cancer, anti-estrogen therapy from a medical perspective is very reasonable. You want to make sure that they are intervening on multiple levels, not just with natural medicine.
Yeah. And then obviously you've got the issue of recurrence, and you've got the issue of, more than one cycle of therapy and how people fare with subsequent cycles, particularly when you've got, let's say, somebody who's obese. They've got a real risk of recurrence because of their body weight, their type of cancer. So you've got a whole pot of negative influences there. Motivation, how they're faring during their cycles of therapy. How do you address all of these things with a positive outcome and hopefully reaching a positive outcome?
Well, I think one of the things to be is realistic as a practitioner.
Yeah.
I'm very lucky in my clinic. I have a fantastic team of practitioners, including an exercise physiologist, acupuncturist, counsellors, psychologists who, are there as a holistic support team. We're a team of practitioners who are supporting patients irrespective of where they are in that treatment spectrum and their experience of oncology, whether they're a new patient or certainly in that prevention of recurrence phase. And having someone, it's all very well us as complementary therapists or naturopaths saying, you need to exercise and this is what we need to do.
You do it when you feel like a hangover.
Well, we've got to get a bit more specific. So, supporting patients to lose weight slowly. We don't really want to lose weight too quickly. That actually liberates estrogen from the cancer cells. So we do want to make sure it's a steady, slow weight loss, no more than about 1 kilo a week.
Yeah, great.
And although, we do also hear that as an excuse, I definitely have heard that with patients saying, my doctor says I can't lose weight quickly. Well, we're not asking you to lose 5 kilos a week. We're saying 0.5 to 1 kilo a week, which is reasonable. And certainly when you're morbidly obese and, if you're projecting ahead, that's 2 years of restricted diet and exercise that you're looking forward to, you definitely need plenty of, emotional support to help you through that and realistic chats with a practitioner who's going to, refer to a team of support people to help that person throughout that process. It's not easy.
Like, I've got to say, like that 1 kilo a week, when you're thinking about a long-term issue, they haven't gotten overweight overnight. So we're talking about something that's a learned or a habitual thing.
But it's actually, it's not just about losing weight, of course. We want to make sure that we're supporting the chemistry of the body. For example, I have a little rule, and that is that, you must have your cardio exercise and your weight-bearing exercise or stretch exercise to a 1-to-1 ratio, because people think that they have to just do cardio to lose weight. In fact, that can be counterproductive. Doing an excessive amount of cardio increases your cortisol levels over time, which then actually can promote an inflammatory process. So we do want to look at the big picture again and say, okay, well, we need to increase your muscle mass. We do a little bit of weight-bearing exercise combined with a fairly low carbohydrate, Mediterranean diet, and just start to have a look at our portion size. I don't recommend calorie counting or anything like that. It's not helpful. And so we want to just sort of do bit by bit to change those habits and promote well-being. And all of that requires, a team of people, especially exercise physiologists. Having someone on hand who can help with that on a very practical level it's a real win from a clinical perspective.
I've got to say, from the work, I think it was Edith Cowan University in Western Australia, haven't exercise physiologists come to the fore lately?
They certainly have. And of course you can, have some subsidised consultations with them, and they certainly know their stuff.
Certainly know their stuff, but good effects in cancer therapy, in cancer outcomes. Brilliant work.
Absolutely.
That they've done over there.
And cardiovascular disease, and often they go hand in hand.
What can you tell us about DNA repair genes, Tanya?
Okay, so certainly DNA repair genes is absolutely the talk of the moment. And everybody who comes in as a patient, I've got plenty of patients who come in and they have already spent the last 2 months pretty much on Dr. Google trying to learn everything they can about DNA.
Right.
I guess when it comes to a clinical perspective, we have to, again, step back and say, right, what do we definitely know about cause and effect inferences when it comes to DNA repair genes and what effect they can have? Most of the research is unfortunately in vitro. So what we have to do is just draw from that what we think is relevant. So we did briefly discuss before about the BRCA1 and 2 genes and how, that is something that the research has shown that the genes themselves can actually be a molecular target for treatment rather than, we've definitely got receptor-focused research up until this point. But then we've got other things like the TP53 or P53 gene. This is a tumour suppressor gene that has been shown to be mutated in over 50% of cancers. Now, there's really not a medical intervention, but certainly there's a lot of research about it. We know from in vitro research that, say, for example, curcumin can convert a mutated P53 into a functional or wild-type P53, which begs the question, does curcumin actually only work in patients that have a mutated P53 gene rather than the functional wild-type? There's questions there. But we've got other natural medicines that have been found to be able to switch on repair of the P53 gene, resveratrol, curcumin, as I said, green tea extract, genistein, and these can be quite important preventative strategies.
Yeah.
Given that we know that, DNA damage occurs over a lifetime. So in prevention of recurrence, we definitely want to be focusing on some of these other DNA repair genes and just switching them on as a matter of course in order to just add to the reduced likelihood of getting a recurrence in the future.
Sure. This is really interesting stuff, isn't it? You're talking about the repair of, something that's been damaged with the 2-hit hypothesis, for instance.
It's
wow,
absolutely fascinating. But again, you can kind of get stuck in a rabbit hole and it just sucks you in. And as a clinician, we really want to know about that kind of thing, but we also want to get ourselves out of that hole and go, okay, how can we actually, let's get back to those cause and effect inferences that are modifiable processes. Let's see how we can intervene in this person's body's chemistry to reduce risk of recurrence in the future and kind of bring it back to those practical levels.
And when you're talking about practical levels, like you think about curcumin, you think about where the research came from. It came from curries. And how much of this stuff can we incorporate into a patient's diet and lifestyle and show them how to eat a little bit differently and then over time maybe if they needed to, a lot differently. But, having a far healthier diet that's going to actually be repairing their DNA, their genes. I mean, that's the powerful thing.
It's very powerful, and certainly it does go back to naturopathy 101 where we're talking about, like food biomedicine.
Yeah.
But it is something that, often when patients are in an active cancer process, they may need supplementation and intense supplementation, like high-dose supplementation of key nutrients in an evidence-based way. But then I guess when it comes to general prevention of recurrence and really just stepping back again and saying, okay, well, what are we going to do as practitioners? What are the big take-home messages here? Certainly we want to assess those risk factors and choose those interventions appropriately. And that requires quite a lot of background research. Working in oncology is not easy. We not only have to know about our own medicine and what that can do, but also how it's going to interact with conventional medicine, which is another complex issue.
But I guess
when we come back and we say, okay, what are we going to do here?
Yeah.
There are some easy things that as a clinician we can support patients. We can look at body weight. Certainly that's often the elephant in the room from a patient's perspective, and we do need to have frank conversations about it, do some motivational interviewing techniques just to help patients prioritise that. But there's key things. Exercise, definitely, especially weight-bearing exercise. A little bit of extended overnight fasting or key fasting. Reducing alcohol, of course, because alcohol is the number one environmental toxin that causes mutations of DNA. We do want to look at the stress response. Stress response, of course, leads to higher inflammation, which can then lead to alteration of the microbiome and breast cancer promotion. So we do want to focus on, the insulin-like growth factor and insulin signaling. And, there's so many other things. General diet, support of making sure you don't have too much exposure to light at night. Shift workers need that extra support. So there's the general things that actually make a huge difference, and just implementing a good, healthy, whole food, low meat, low dairy, low carbohydrate, but high nutrient-dense, varied diet is one of the first things that we can do, and that's pretty easy.
I remember Lee's giving me a very salient lesson about eat a rainbow every day, but not including textures.
That's right. Every day sometimes is a bit hard, but I get people to look at, okay, let's have a rainbow in a week, make sure that we've definitely got every colour.
Yeah.
And that's the thing, sometimes we just need to give the right easy recipes, give ideas of what we eat, you know, to help patients, come up with new ideas. We tend to eat very samey.
Yeah.
Nice to have some new ideas.
Yes. So about preventing recurrence, and, one of the elephants in the room is the ongoing hyper-vigilance of patients. How do you address that?
That's a really tough one. And that is something that's very difficult to manage. Certainly the fear of recurrence and that tendency to be hyper-vigilant is completely normal. So what we're wanting to do is just rationalise it, work out how we can live with that reality. We definitely have psychologists here who are very experienced in supporting patients to manage fear of recurrence. And I guess this is the thing, when you've got a practitioner who is supporting you in prevention of recurrence or known prevention of recurrence strategies, obviously there's never a guarantee about that, but certainly there are known prevention of recurrence strategies that when you are implementing them as a patient, it gives you a huge level of confidence in your future. So you're not just flailing at the end of your process, medical procedures, and just off on your own. You are actually following a plan.
Yeah. And
that plan can give you confidence and reduce that fear of recurrence. It is something that's really important because, when a patient's in the process of having treatment, they are just putting one step in front of the other, getting through the day, getting through the next treatment, and there's no time for processing. It's at the end when, the doctors are like, oh, well, you don't need to come back for another 6 months. Off you go, get back to your life. That person is sitting there going, what? What do you mean get back to my life? My life is never going to be the same.
It's changed, yeah, that's right.
And patients are, in that perfect space to actually have almost like a post-traumatic stress disorder present itself.
Absolutely.
And that's when that person really needs psychology support. So that's where it's very important to have key practitioners who are experienced in psycho-oncology support to be able to help that person in that moment. And then for us, our role is to help that person have a plan of enhancing wellness, reducing risk factors, and that actually gives you a huge level of confidence in your future.
We've learnt so much from your expertise here today, Tanya, I've got to say, and you've given me a couple of bricks to the head which have woken me up about a red flag, and that was renal disease when you're looking at what diet to initiate. And so we've learnt about that. What other red flags do we have to be mindful of, just quickly?
I guess the other red flags are the biggest red flags, of course, are looking at drug-herb interactions and drug-nutrient interactions.
Yep.
And any other pre-existing conditions that, from a prevention of recurrence perspective, we've got young women, if we're talking about ER-positive breast cancer specifically, most of the patients that I'm seeing with that presentation are between the age of 40 and 30 and 60. Mm-hmm. Cardiovascular disease is not necessarily the number one issue there, but certainly drug-herb interactions is definitely one of the biggest red flags that we'd be looking out for, to make sure that anything that we're going to promote isn't going to interfere with any other treatment. Sure.
Tanya, I cannot thank you enough from a personal level, but your expertise shines. Tanya Wells, thank you so much for taking through just a glimmer of your expertise today on FX Medicine. I personally truly thank you. I'm so honoured to meet you and have you on the show.
Thanks very much, Andrew. It's my pleasure.
This is FX Medicine. I'm Andrew Whitfield Cook. To conclude his distinguished career, legendary Australian herbalist Dennis Stewart will present his final course, a professional extension in herbal medicine. Commencing on the 23rd of November 2019, this 12-day intensive course will be held over a period of 12 months on the New South Wales Central Coast. This will be your last opportunity to participate in detailed learning with Dennis, covering relevant, effective herbal prescriptions to treat an expansive range of conditions. For more information and to register, please go to lakespa.com.au.